A 17-year-old boy loses consciousness after being hit on the head while playing sport. He regains consciousness but is increasingly confused with tenderness and bruising over the right parietal area. The figure demonstrates a CT scan of the head and is included in the picture. Which is the most likely diagnosis? A. Diffuse axonal injury. B. Extradural hematoma. C. Intraventricular hemorrhage. D. Subarachnoid hemorrhage. Or E. Subdural hematoma. Now pause the video here and give yourself about 30 seconds to think about the correct answer. So the correct answer in this case is B, an extradural hematoma. And we'll go through why in the following slides. So an extradural hematoma describes a collection of blood between the inner skull table and the parietal layer of the dura, otherwise known as the periosteum. They typically occur after a head injury with associated vascular trauma, and there may or may not be an underlying skull fracture. They most commonly present in those aged 20 to 30 years after high-impact sporting injuries. So symptoms include a head injury, commonly after sport or motor vehicle accident, and there may be associated bruising or bleeding associated with this, and skin trauma. The core symptoms include an initial loss of consciousness, followed by a transient regaining consciousness described as the lucid interval, and subsequent gradual deterioration in GCS. There may be a headache and features of raised intracranial pressure, such as an associated cranial nerve injury, typically relating to the abducens nerve due to its long intracerebral course, and there may be features like papilloedema on fundoscopy. As previously mentioned, they typically occur after head trauma, but there may be association with infection, coagulopathies that increase the bleeding risk, dural vascular malformation, and dural metastasis. The pathophysiology, they most commonly occur as an arterial bleed, typically the rupture of the middle meningeal artery at the pterium, which is the thinnest part of the skull and the site at which the middle meningeal artery lies in closest proximity. Venous bleeds are rare but may occur due to trauma to the middle meningeal vein, a dural venous sinus, or a rupture of a dural venous malformation. The imaging required in any head trauma is an emergent non-contrast CT head. The typical radiographic features include a biconvex or a lentiform hyperdensity, typically limited by the cranial sutures, and there may be associated mass effect as seen in this CT image with a shift of the false cerebri to the other side to the hematoma. There may be features of an underlying skull fracture. Initially, the initial scan may be normal in those with a delayed bleed, but can quickly expand with associated clinical deterioration. So you have to watch out for this in anyone with a history of head trauma. In the emergency setting, an assessment of GCS is essential, and serial GCSs are required in the assessment of anyone with a significant head trauma. Here is an overview of the Glasgow Coma Scale. The key features of the Glasgow Coma Scale are spontaneous eye opening, a motor response with obeying of commands, and a verbal response with orientated speech. With subsequent clinical deterioration, you'll see a decrease in GCS. An extradural hematoma is a neurosurgical emergency and should be managed with an A to E approach with a primary survey, appropriate resuscitation and neuroprotective measures, including controlling the intracranial pressure with elevation of the head of the bed, and there's various agents such as mannitol that can be used to reduce intracranial pressure if this is significantly elevated. It's essential to maintain blood pressure, oxygenation, temperature, blood sugar and electrolytes to within homeostatic levels, and there should be stabilization of any other acute and life-threatening injuries, including clearance of the C-spine. It is essential to have close ongoing neurological monitoring and a neurosurgical consult in any intracranial hemorrhage. Again, with reference to the Glasgow Coma Scale, close neurological monitoring is essential. Definitive management strategies include conservative management with serial CT scans for those with minimal and improving symptoms and small bleeds with non-clinically significant disruption to the brain parenchyma, and this is typical for most patients with extradural hematoma. For those with any significant midline shift noted on CT, focal neurology, including localizing features of sensory or motor impairment, and a GCS below 8, surgical management is essential. This can include a craniotomy and a hematoma evacuation with ligation of any bleeding vessels. Burr hole surgery can also be considered as a temporizing procedure where neurosurgical expertise is not closely and immediately available, and the patient should be managed post-operatively in neurosurgical critical care, where the close monitoring required can be established. And just going back to the question, the key features in the question that help us to get the diagnosis include the loss of consciousness after head trauma while playing sport. He regains consciousness with the lucid interval, but is increasingly confused, and there are features of head injury in the most common area affected of an extradural hematoma. The CT shows a biconvex lentiform hyperdensity over the parietal area with associated mild midline shift. Hence the correct answer is an extradural hematoma.